Hi, welcome to Trainer Talk. It's December, the end of 2015, and I have here with me Dr. Paul Greenman. I'm so excited to have you here today, Paul, and to learn some of the things that you're doing in relation to EFT research and with behavioral medicine and just health overall in EFT.
Glad to be here.
So let me give our audience a little introduction to you. You are a trainer for ICEEFT. You're a therapist and a supervisor, full-time professor of clinical psych at the University of Quebec. And you provide services to clients at the OCFI, the Ottawa Couple and Family Clinic, there in Ottawa with Sue and the team there. And also at a hospital in Ottawa, you're also involved in providing services there in behavioral health at the hospital. And you have a really strong interest in providing psychological treatments to patients in medical settings, and you're overseeing some research projects in that, which we're going to hear about. And you also speak numerous languages and travel around the world teaching EFT, both teach it in French, in German, in Italian, and in English. So it's just so exciting to have you with your depth of experience and your wealth of knowledge to have you on the team with us.
Thanks, Becca. It's great.
So I'm so
Yeah,
glad to have you here.
great to be part of it.
So we're going to talk today a little bit. Oh, go ahead. Sorry.
Just saying it's great
Got
to
all
be a part
excited.
of the team, I could talk about EFT for hours. So you might have to give me the, slow me down a little bit.
Yeah, I know that feeling. So, we're talking today about some of the new research. You've been involved in some pilot work on with EFT and behavioral medicine. So why don't you launch in a
Sure. This is work that we started about 5 years ago. My colleagues and students at the Montfort Hospital, where I work as part of the family medicine unit. And one of the mandates of the family medicine unit is actually providing psychological services to patients. So I'm actually part of the clinical health psychology team there. And a few years ago, I thought it would really be nice if, in addition to the more traditional individual therapy interventions, group therapy interventions that are very CBT based, I thought it would be really neat if we could get EFT for couples up and running, not just for research purposes, but clinically. So that could be part of the umbrella of services that we provide. So that happened, and once we got that established, EFT is now regularly offered at the family medicine unit at the Montfort Hospital in Ottawa. That enabled us to train graduate students, to provide supervision to graduate students, and now to do some research to see how we can tailor EFT to help people with chronic physical illnesses. So there was one. This is all pilot work because it's just getting off the ground now, but it's pretty exciting stuff. In the first study, which started about 5 years ago and finished up about 3 years ago, and we're still looking at the data from it now, we applied emotionally focused therapy for couples in which one of the partners was suffering from heart disease. So recently, one person had had a heart attack, or if they didn't have a heart attack, they had maybe a bypass operation, had stents installed. And we found, just like in healthy couples, we found that EFT was helpful in increasing relationship satisfaction, increasing intimacy, emotional intimacy, and sexual intimacy. And we also found that in one case, it was actually very helpful for a patient who had been suffering from PTSD symptoms as a result of his cardiac disease. Another neat twist to that study was because it was all of the sessions were recorded, we were able to start doing some process research, looking at stage one, and specifically figuring out if stage one proceeds the way that we kind of think it does based on the different manuals that are out there. Sue's book, the workbook. So one of my graduate students looked at the process of de-escalation, and found, kind of like the in the blamer softening, the pursuer softening theory from Bradley and Furrow, found that there, in our sample, were a series of steps that led to a de-escalation that would involve each partner talking about their fears of opening up, their fears of being vulnerable, and eventually by the end of stage one being more receptive to the other partner. What was interesting was that that process was slightly different for cardiac couples. We found that pursuing partners in couples in which one person had heart disease were less likely to express a desire to respond to the emotional needs of their withdrawer and to experience more intense emotional responses before leading to de-escalation. So that was an interesting
That was
difference.
the person with, yeah,
Other studies.
1 second, let's go back for a minute. In your original
Sure.
heart studies with the cardiac patients, how did people decide, how did you choose who got EFT? I mean, were they people that were, you just
Oh,
assumed they were in distress because they were under medical care, or were they under distress? What did that look like as they entered?
everyone in the sample received EFT. Subjects served as their own controls in the sample. So we did what's called a multiple baseline design, looking at them before treatment was implemented, during treatment, and then after treatment. And we had a cutoff. They had to be below 97 on the DAS in order to be included in the
And some of
sample.
them got EFT and some of them got nothing, or
All no, they
all got
they
EFT.
all
Oh,
got
that's
EFT.
fantastic. Cool. Okay, that I just had that question going forward. And so then this process of de-escalation, you found, I'm so excited to hear more about that because I've been teaching and writing about, and I didn't know you were studying that. We should have paid more to, or we should have connected up on this sooner because Paul Aiken and I have been writing a paper about the process of de-escalation that I outlined, that I've seen over my years of doing EFT, um, and seeing that really seeing de-escalation as a process. So I'm very curious about what kinds of things you saw. And it sounds like you may be framing it up a little bit different than I was conceptualizing it. So I'm really curious about that.
Yeah, and this was a project that my one of my graduate students, who's now finished her doctorate, that she really spearheaded. She basically did a task analysis of based on sort of Greenberg's work, doing task analyses for different interventions in therapy, and she looked specifically at the pursuing partner and the withdrawing partner, and if they followed a specific series of steps before achieving de-escalation. And what she found was that, and again, this is a very small sample, Becca. This is a pilot study, so we're talking about 2 cardiac couples and 2 couples who were in good health, just to sort of get the ball rolling. But what she found was that across couples, uh, there were some common milestones, if you will, in the stage one work. So looking at um, the pursuing partner, starting off by being critical, and then we observed in all cases the withdrawn partner defending himself or herself. But then they started talking in more detail with the therapist's help about their fears specifically of making themselves vulnerable to the other person. And there was a series of exchanges then, back and forth between the pursuing and the withdrawn partner that led up to de-escalation. It wasn't so different from what we see clinically, but it was nice to have some empirical evidence of this mini theory. And what we found, though, was that for cardiac couples, the process was a little bit different. In cardiac couples, uh, it wasn't so much a condition of de-escalation that the pursuing partner recognized the withdrawn partner's efforts to keep the relationship going. So there were some detail type things that were different between the two couples. And part of the reason we think that is because in the cardiac couples, the pursuing partner was experiencing a lot more intense emotion. So there was some process markers, and there was also we also used the experiencing scale and the SASB to assess what was going on. And the idea that pursuing partner in a cardiac couple would be experiencing more emotion kind of makes sense when you think about how chronic illnesses can really activate uh, attachment fears and attachment needs. So we're still working on the analysis of that, and I'm trying very hard to get that study out, to get it published, hopefully early on in the new year. And definitely will have to be I definitely would want to be talking with you and with Paul Aiken about that to see how, what we found, um, uh, see how it gels with what you've written and what you've observed clinically. But the take-home message was there do appear to be a series of
Right.
steps, kind of like with the pursuer softening, a series of steps that involve both partners speaking directly to each other about their fears, but specifically the fear of being vulnerable. So the therapist would say things like, "What would happen if? What would happen if the next time you were feeling really alone and afraid, and like no one understood you since your heart attack? What would happen if you went to your partner and talked about that?" And at first, there was this sort of, well, I couldn't do that. I mean, he wouldn't understand or she wouldn't understand. Everybody's telling me, I should be happy just to be alive. I can't make myself vulnerable. So there were, and in healthy couples too, there was a real exchange of fears, but fears specific to making themselves vulnerable to the other partner that appeared to be really
Cardiac
crucial
couples, that
for
was
de-escalation.
there
So
was
that was
even
neat.
more resistance, more fears around doing that.
Heightened, more intense fear and more intense need
Yes, of course, that
from
makes so
both
much sense,
partners.
doesn't it? Um, okay, go ahead.
So sure. So there was another study that again smaller sample that led spearheaded by another one of my former graduate students, where she looked at EFT and postpartum depression, and she found that in her sample of couples of new mothers, that EFT, again doing a multiple baseline design using mothers and their partners as their own controls, so measuring them before, during, and after treatment, found that EFT was effective at reducing symptoms of postpartum depression in all mothers. And in one case, even one of the dads who was experiencing depression at the same time as his partner, his depression, his mood also lifted. So this is some preliminary evidence
And
of
Paul, were
EFT's
those
efficacy
subjects
for
with
postpartum
or
depression.
without
And
medication
then
alongside? Do you know?
there were some subjects who were taking medication. But again, one of the benefits of this design, because I see one of the questions is, were these random assignment studies? No, these were pilot investigations using what's called a multiple baseline design. And what that means is there are controls, but subjects serve as their own controls. So you look at each couple or each individual in each couple for an extended period of time, say every day for 2 months before you start treatment. And then every day during treatment, they would fill out questionnaires. And then again, once treatment was over. So in this way, you can really see change for each individual. And it's actually kind of an advantage over more traditional large group studies where you're looking at means, because you can't really generalize mean differences to a specific person. Whereas when you do this kind of work, you can say, well, we know that for person A, EFT really helped to lift her depression. But yes, this is pilot work, and all of these studies are begging for a larger sample, which is something that we're doing now in a project that's been funded here in Canada by the Movember Foundation, We're looking at mental health and heart disease in men, and one of the treatments we're offering them is EFT for couples. So really looking at the relationship and how men's relationships with their partners can help them overcome symptoms of depression or anxiety or post-traumatic stress in line with their heart disease. Thanks, Valerie. Yeah, I'm working very hard to get this study up. There was just a comment there that it's um, the developmental model is important for sure, and for sure we do need to have some more randomization. However, this kind of design really does allow you to make conclusions about whether or not a particular approach was effective for a particular individual. It doesn't allow necessarily
Right.
generalization to the larger
Right,
population.
because you do have that period before treatment as well, right? So you can
So there
really
was a
see the impact of the treatment.
right, yeah, 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 yeah. And a subject, what's interesting is subjects serve as their own control, so they'll establish a baseline. And my level of depression at the beginning of the study might be higher or lower than someone else's, but the results of the treatment are based on my results and my process of change. So it's a different way of looking at it. But we absolutely, in the Movember study, we're going to be recruiting 3,000 men to have a sample size large enough to help us make some more
Wow.
causal inferences. So we're pretty excited about that. There was another study where we looked at EFT and individual CBT for depression and diabetes. And we found in that study where there was random assignment that EFT and CBT were about as effective for helping patients overcome their depression. And also, the treatments appeared to help them manage their diabetes a bit better. So once the depression lifted, they were better able to follow the instructions from their physician, for example. Again, this is a small sample, but we're preparing a grant proposal now using these
What kind
pilot
of
data
modifications,
where we
if
want to
any,
do a
Paul,
much
have
larger
been were
randomized
put like
controlled trial.
into that? Is the
And finally,
depression or the illness kind of put into the cycle, or how do you handle that piece of it?
yeah, in all cases, when you're doing EFT with people with chronic illness, you look at how the illness has affected the relationship. So not only how it's affected each individual partner, which is really important, because again, you can think of all of the attachment fears that get activated when, I had one client say, my husband is trying to kill himself. He went and he bought a bag of peanuts and a bottle of whiskey on his way home from the doctor's office. Well, I don't want to have anything to do with that. These are the kinds of attachment fears that get brought about because of the illness. Whether the relationship was secure beforehand or not, we really have to have a look at how the illness is affecting each person individually, and then, of course, how that affects the dance they do. So the simple answer to your question, Becca, is yes, we put the illness in the context of the cycle. But we understand though that it can be different depending on the couple. There are some couples who say things like, you didn't shed one single tear when you found out that I was ill. And others say, well, I don't mind that you didn't shed a tear, but I really feel like you've completely abandoned me since I've really needed you. Or coming to terms with their own mortality or with their partner's mortality. These are all things that activate attachment fears and
So you
behaviors
put
according to people's typical ways of
a negative
interacting with each other.
cycle that you so in trauma, I mean, I know how I do it with sexual addictions and how I do it with trauma. You kind of frame the negative cycle around the illness, but is that, or did you say you're framing the illness around the cycle? I wasn't sure what you said. You're putting the negative cycle in the context of the chronic illness that they're facing.
In the context of the illness. Right. And for some couples, the illness will be front and center. So maybe things were fine before, but now ever since the heart attack, he's finding that she's really nagging him and saying things like, "You're having bacon again, and you think you're going hiking? No way." Uh, but in reality, what's going on is those are the attachment fears that are being activated. So um, it's really a question of understanding how for each particular couple the illness has affected them. For some of them, it's created a cycle that wasn't there before. For others, it's made a cycle worse that was already happening. So I don't know how you'd put that. Is
Well, it
that sort
sounds
of
like
inserting the illness into
it's
the cycle, or
both, a
the
little bit
cycle
of
into
both,
the
right? The
illness?
context is that they have this thing that they're fighting together, which is the illness. That when they're reactive, it both increases the impact of the illness physically and also of the negative cycle. Wow, that's really big.
Yeah, yeah. And the last adaptation, and this we're working on with Sue and with some colleagues at the University of Ottawa Heart Institute, is we've almost finished our first run through of Hold Me Tight groups that have been reworked for cardiac couples. So basically going through the Hold Me Tight conversations, but doing that within the context of heart disease. So in those groups, we've been talking about um, how disease has affected the couple, how it's affected each partner, how it can activate those kinds of deep-seated fears, and how partners can talk to each other more openly and directly about those fears, as opposed to falling into the sort of criticize, defend traps that are common elsewhere. And that is going to be a very large randomized study where some couples are going to be randomized into the cardiac hold me tight, which we're calling healing hearts together. And other couples will be receiving treatment as
Right. So
usual as
you're
part of their
so
cardiac
EFT is
rehabilitation
helping these
program.
couples, grow more secure together in in the face of these very severe illnesses. And they're also impacting the illness. So it's not only helping the negative cycle, but um, in heart disease and the depression, you're also seeing it impact the depression.
We found that with diabetes. We found that with depression. And we're hoping that we'll find that on biological measures of things like blood pressure, cholesterol, in the Healing Hearts Together study and in the larger Movember study. So yes, we are starting to look at not just measures of relationship satisfaction, but also can improvement in relationships and couple relationships lead to improvements in mental health and physical health. And but we're at the very beginning of this. Again, I can't stress that enough. I'm really excited about these studies, but they are all pilot studies that have led to now two larger scale studies that are just getting
Yes, I'd
underway.
say.
So we have a
Well,
long way to go.
the
But it's good
postpartum
because it'll keep
depression
me
study
busy
is
for a
relatively
while.
new, but we have had some outcome around depression in addition to what you're studying now, isn't that right?
Yep. There was a study in the early 2000s, Andre Desaulles, who was one of Sue's students, and then more recently, Wayne Denton's work has looked into EFT and depression. And in the early study, it was found that EFT for couples was actually
That study too.
more effective than antidepressants were. I love that study from 2003. And more recently, though, it's looking like EFT is an excellent supplement to pharmacological interventions. And again, all of this makes sense if you think of the attachment model, right? I mean, if people can really allow themselves, can really feel loved and supported by their partners, if they can let that in and it's really there for them, it makes sense that they would be less, less sad and happier in their lives. But if something's blocking that, that can be a
Yeah, that's
huge
really lovely.
contributor to depression,
So
as I
in
think
these
everybody knows.
studies with your students, you're providing some EFT training for them, and would you like kind of how far along the training path are they before you say, yeah, this is, good enough EFT that this is EFT, and we know that this is what's, we can see that that's what's making.
Yeah. Well, the nice one of the many really nice things about being a professor is that I get to know the students really well, especially graduate students, uh, starting in their courses and then through their practicum training and then their internship training. And the one of the requisites for being a therapist in my studies is I ask that all students have either taken my EFT course, my graduate 3 credit EFT course, or SUE's, or the equivalent at the University of Ottawa. And then uh, there's a minimum number of, it's not really a number of couples, but I really want to observe them as they're applying EFT in a supervised context as part of a practicum before I would invite them to be a therapist in the study. So it involves sort of the basic training. Some of the therapists have also decided to complete externships. There's even one who's gone all the way through to core skills, who's still a graduate student. But the important thing is to have the EFT training either with me or with Sue. And I keep saying that, but Sue's retired from Ottawa U now, so I think our colleague Normand Gingras, he teaches EFT there at the University of Ottawa. It's important that they have at least that basic training and then sufficient supervised practice, either by me or other certified supervisors, before I ask them to be a therapist in
Right.
the study.
Makes a lot.
And yes, they are lucky to get EFT in grad school. I was lucky to get EFT in grad school too. That's where it all started for me. Sue was my teacher. She
And is
taught
that kind of equivalent to the
the couple
externship,
therapy
Paul?
course that I took. That's where I got to know her. Yes. It's similar, and actually, there's a lot of the material in the graduate course that is in the externship. So the basic outlining attachment theory and how it relates to couples, and then outlining how a therapist can really draw actively on attachment theory at each one of the steps and stages of EFT. So there are definitely there's definitely a lot of material in the graduate course that's also present in an externship. But some stuff that's more so for the graduate course. I talk a little bit more about other approaches, just so people have a sense of what else is out there, and how EFT is different from that. Don't talk so much about the certification process, but as far as the details of the steps and stages, yes, there's definitely a lot of overlap between it. There's not as much
That's right.
practical
Oh,
work as I would like.
yeah,
Is
that's
often
really
the
helpful if they
case.
can do that. We have a
I try
similar
to get them
course
practicing.
at Alliant International that I've taught, and Dr. Mark Kopp has taught, and Dr. Scott Woolley has taught. That advanced couples course, and survey a few of the other couple therapies, but spend most of the time on EFT. And then I think we also did a lot of practice. And some years we set it up so that we were bringing live demos in as part of the course as well, because the students would be in their internships or practicums and have to be working with couples, and they could bring those couples in. It was pretty cool. So Valerie's asking, yeah, so they would bring in some of their own couples and would do live demos with them.
Wow. Okay. So
Some years would just follow one couple, kind of like Gail does, one couple the whole semester. Sometimes it would give the opportunity for every student to bring a couple of, based on their practicum or internship if they had them. So it was pretty cool. And, it's so nice, isn't it, as students, as a professional learning EFT, I had a bunch of stumbling blocks to get around from previous training.
See, so you worked from a different model at one point, Becca? Okay. See, I never did. I never, so I didn't have to unlearn anything. It's like when I started playing golf recently, and my
Yeah, it's a
professor
little
said, it's good
trickier for
that
those
you've
of us who
never
are
played
licensed
before
professionals
because you
already
don't have
when we're
anything to unlearn.
trying to learn EFT, because there is some, unlearning or relearning, learning new automatic ways of responding, really, right?
I find that EFT, though, is a very integrative approach. I mean, there are behavioral components. There are definitely psychodynamic components. I mean, when we're working at step 5 and we're heightening the person's in the moment vulnerabilities and fears and shame reactions, and we're linking them to certain past experiences for validation. I mean, that's very psychodynamic. The Stage 3, when we're helping clients to do their own problem solving, that's very behavioral. Attachment rituals are about behavior, right? So I think EFT really is an integrative approach. Valerie's asked a question about a good summary of secure attachment in relationships. I do have a reference for that. It's actually a book, though. This just came out a couple years ago, but it's terrific. It's called Health and Social Relationships: The Good, the Bad, and the Complicated. And there's a great chapter in here. They're all great, but there's a really good chapter about attachment and health outcomes. And article by Paula Pietramonaco, who talks about the usefulness of attachment theory health settings, and it's a call for more measurement of attachment and attachment security. There's also a chapter, and I can circulate this, that I wrote with a student of mine and a colleague at the Heart Institute, where we summarize the importance of secure attachment and heart disease outcomes. So I'd be happy to forward that along. It's in a book that came out last year about different types of
I
couple
can
therapy
put it
for
alongside the
physical illnesses.
recording of this for other people as they come along. Yeah, if you want to email that over to me, that'd be really great. So yeah, that'd be great. Okay.
Okay.
So
Becca,
as you
I'll
were
email you
talking about the behavioral,
I'll
some of the
email you the
behavioral
specific.
things that we
Okay.
are doing in EFT, certainly stage 3, there's things where we help people, we help them problem solve and that sort of thing. I'm also really interested in Jonathan Sandberg's newest research on the brief ARE, and where he calls accessibility, responsiveness, and engagement a behavioral response, which I think is kind of interesting because it's something that can be measured and looked at. And has a little survey, the brief ARE, that's shown to be more viable for the outcome and for couple satisfaction than attachment style, for example. So, I mean, I think some of these processes that were involved, they're not traditionally behavioral, but they are responses that we can see, that the partner can see, and that we can kind of maybe think about in those ways that we can be monitoring them in
Absolutely.
session.
Absolutely. And when you're doing stage one with clients, I know that I always ask about, I always say the cycle. What is the cycle? The cycle is primary emotion, so it's what people are feeling. Secondary emotion is what they're showing, and it's about what they're doing. So when we're asking clients, so what's that like for you? As the two of you are arguing about your in-laws, and he's feeling, um, and you say you're getting really worked up and really riled up, and you're feeling like, oh, once again, he's not listening to me or not understanding me, and you're feeling really alone. What do you do? What do you do when you feel alone in that way and when you feel sad in that way? And then we ask the partner how he or she responds to what the other person has done. There's always in EFT a behavioral component in the sense that we're asking people to be aware of what they do when they feel certain things
Always
and
looking at that
how
cue,
what they do affects their
that
partner.
that cue that comes in that people will see by the expression, by something they're actually doing, by that outside element that certainly we could look at as behavioral, that action tendency. Yep. And accessibility and responsiveness and engagement is something that people can kind of do and be with each other.
Yeah, action
It's kind of an
tendency
interesting
is.
way to think about it. So what kind of, let's go back to the postpartum depression study.
Absolutely.
When you're looking at how severe were those mothers that you were working with, those couples that you were working with on the depression spectrum?
We administered the BDI, the Beck Depression Inventory, and actually the fast screen. Just because the longer BDI, there are a lot of questions on it that might actually get confused with physical illnesses, so things like sleepiness or appetite. The BDI fast screen really focuses on the mood, focuses on sadness, suicidal ideation, and it's been shown to be just as valid as the longer Beck. So initially, we wanted everyone who was going to be participating in the study to be in the uh, moderate to severe range. We had some recruitment problems, so we opened that up a bit, but there had to be minimally significant depressive symptoms as measured by um, moderate depressive symptomatology on the back. So as kind of we didn't want to be looking at mothers who were minimally depressed or not depressed at all. We also didn't want mothers who were maybe severely depressed and had been for many years. It was really limited to the onset of depression following delivery
Oh,
of
that's great.
their first
So
child,
can you talk a
and
little
that
bit
had to
about
be of
recruitment
moderate
and
severity as
also
measured
if
by the
there's,
BDI.
um, do you need other clinicians to be involved, say if they are certified or there's some way, or is it kind of just right within the university that you're doing this?
No, it's very important wherever possible that other clinicians be involved. I mean, one thing I've learned uh, is in 10 years of doing this, it's doing clinical research is really hard. And it's hard mostly from a logistical standpoint. It's hard getting people into the study that meet the criteria. It's hard keeping them there. And it's hard then having all of the infrastructure that's necessary to do good work. So I rely heavily on graduate students who have either been trained by me or other certified EFT supervisors. But more and more now, also looking to colleagues. And I know in some of the studies we've done at the Ottawa Couple and Family Institute, where there have been several members of the institute doing therapy as part of the study. You know, I've talked a lot today about my research, but my colleagues Melissa Burgess Moser, Stephanie Wiebe, Tracy Dalgleish, they've all recently published work on EFT looking at changes in relationship-specific attachment. You know, looking at how EFT actually does change attachment the way we always knew it did, but now we have proof of that, scientific proof of that. Um, and then Tracy's done some really interesting work looking at how that change comes about. And these studies, there are a team of therapists from the Ottawa Couple and Family Institute and other sites in the community, because you really do have to have that. It's almost impossible to do meaningful psychotherapy research by oneself unless you do sort of really advanced case study type work, which can be useful. But as far as really getting into the process work, it's an enormous effort just to make sure the therapy is getting done and getting done well. And then, especially for process
It's
research,
huge.
going through all of the steps to actually code and make sense of what's been observed. So it's a lot, and it can't be done by one partner. But that's attachment, right? You know,
So
we
your
need each other.
interest
We
in
rely on each other to
behavioral
be able to
health and
get
medicine,
these
is
projects
that
up
something that
and
you
running and to
came
keep them
into
up.
the university with, into your education with, or did that develop as you were kind of?
It started when I was a practicum student. One of the rotations I did when I was doing my doctorate at the University of Ottawa was at the hospital where I work now, under the supervision of a man who's become a good colleague and friend. And so it was there where I was first exposed to the idea of doing psychology in family medicine. And then when I was an intern for the entire internship year, I spent 2 days a week at that rotation, and that's where I really started getting interested in uh, the um, the cardiology angle, because at the time, this was in 2004, they were opening up a new cardiac rehabilitation clinic, and they were looking to insert psychology in there as well. So that's where it really started for me, was sort of taking what I had learned in a university setting, which is kind of more like a private practice setting when you think about it. So these university clinics, we serve a wide cross section of people, but it's not the same as working in a public hospital, especially a public hospital in Canada, where we see pretty much anything you can imagine, especially in family medicine. Um, so I was really excited about just developing psychological treatments to help people with chronic illness to get through a lot of the levels of depression and anxiety and post-traumatic stress are through the roof for things like heart disease and even diabetes. And so I started as an intern getting involved in that clinically. And then from day one, I knew I wanted eventually to try to introduce EFT for couples into these settings where individual CBT and group CBT pretty much dominated. And so far, so good.
Any question,
It
isn't
was
it?
at first a tough sell. I
Like it's
had
family
administrators
medicine.
saying, why should we be doing marriage counseling in family medicine? And
Right.
right, right. But the idea was, how is working on the marriage, going to help this patient who's not taking his meds or not taking her insulin or what have you? And but they were open to it. I just talked a little bit about what we know about the links between social support and health, and how even when you control for things like cigarette smoking and alcohol use and exercise, loneliness is every bit as toxic, if not more so. There was a recent study that showed that loneliness,
Wow.
or being in a positive marriage, in a couple relationship, for cancer patients was actually more effective in some cases than chemotherapy. Think about what that means. And so when you show up in medical settings with information like that, well, then people are really open to it. And plus, people who work with these patients on a daily basis do understand that,
Right.
all the
Right.
best advice in the world, but if they're preoccupied by a relationship that's not going well, uh, it's really hard for them to follow any meaningful medical advice. Maybe I should key for doctors. Oh, we get that. Oh, they they have started knocking on our door,
So,
outside of a research
so
context.
Paul,
Yes,
do you have a
when
sense,
they hear
because
us
there was
talk
already
about it,
some
for sure.
ongoing programs before EFT, um, some sense of how much services or how many couples, like say for example, let's say if we just took heart disease, how many couples that does precipitate distress on their relationship? Like, is it the majority of couples that face a chronic illness?
Well, that depends, Becca. It really depends, as you could probably guess, on the quality of the attachment bond before. So couples who uh, have a very, very strong relationship, who are able to come together in moments of need and of vulnerability, yeah, they might be in considerable distress. They might even show signs of a kind of pursue withdraw cycle once the illness is diagnosed, but they can usually see what's happening, and work their way out of it. Gradually, those couples without therapy, you're eating bacon again, becomes, I'm really worried about you because I don't want you to die because I love you. Uh, and so those couples, they can get through it. They benefit, and we're seeing some of this in the groups. Some of those couples will benefit anyway just from learning a little bit more about attachment and about how to be responsive and engaged and attuned. Um, but other couples, no.
Just
For
more
other
than they can
couples, the
bear.
illness,
Yeah.
maybe it brings up an old attachment injury, or um, it just kind of is like the straw that breaks. Yeah, it could be the straw that breaks the camel's back, in terms of, okay, I managed to feel okay in this relationship for a long time, but now that there's this really, really aggressive dragon in the room, I don't know if I can really do that anymore. But I don't have statistics on that. That would be interesting to sort of see, what percentage of couples who face chronic illness would necessarily develop. I know that for different types of diseases, one of the known consequences of diabetes, for example, or heart disease, is a,
So it seems
heightened
like it would
risk
be
for developing
more than the general
relationship
population
dissatisfaction.
of
That we do
couples.
know, that
If
any kind of
it does
chronic
heighten their
stressor
risk. Yeah.
puts a couple at risk,
Right.
especially things like. Well, it's another risk factor, like having a sick child, for example, or taking care of an elderly
Right.
parent who lives in the
So Valerie
home. I
had
mean,
this
these
other
are all
question
things
about, do you have a
that can
sense of, what do
contribute
you
to
think is the
stress, and
most
then
reliable
how we deal with
questionnaire
stress
or measure
uh,
for
can
attachment
affect our
style?
cycle.
Do you have a favorite?
For attachments,
Yeah.
um, I prefer there's a questionnaire. It's very recent, and it's a reworking of the
Oh,
experiences and close relationship scale. It was reworked by Sue Philshaver and our colleague Marie-France Lafontaine at the University of Ottawa. It's the ECR 12, and I like it for a couple reasons. One is it's not very long, and it gives you a sense of how people are in their romantic relationships. But another reason I really like it is because it's been validated in French. So when I use it here, I know that I'm using a valid measure with which French-speaking populations in Canada, and that's not always easy to come by.
right.
But in general, I prefer to look clinically and in research a bit more at the attachment bond in the couple. I find attachment style is useful in that it helps me understand each person's sort of default option. But what I really want to know about is how does this person feel in this relationship? I mean, someone could have a really secure style, but be in a relationship with a really, really aggressive, nasty person, and then that person might start to feel anxious or unsure. The opposite's also true. Someone might have a more preoccupied style, but be in a relationship with someone who uh,
Right.
who really makes them feel safe and secure. So then, despite their kind of anxious, preoccupied style, the attachment bond in the relationship is really secure. And how do you measure that? It's a newer measure. It came out in 2011. It's called the Experiences in Close Relationship Style. It looks at types of attachment relationships. So it asks people how safe and close they feel with their mother or their best friend or their boyfriend or their girlfriend.
Well,
So it
I'm
basically
with you
allows for
that there's
that.
things that are
In the
more,
literature, they're calling it
um, the only reason I
relationship
really like
specific
attachment
attachment. But
style
what do you think, Becca?
questionnaires
What
clinically is to orient the couple to the kinds of things that I kind of think matter in therapy. And now that we have the the BARE, the brief accessibility, responsiveness, and engagement scale, I'm starting to use that, and I think that that's great because the scale itself, and I'll pull it in so people can download it. I'll share this file with you. The scale itself has been tested and shown to be more important for outcome, predicting
oh,
outcome and
great.
distress, that it matters more, the accessibility, responsiveness, and engagement using this instrument than attachment style does. So,
And that doesn't surprise me at all, Becca, because I mean, I love attachment and I love attachment theory,
right,
okay? But one thing that I just found, how do I put this? Unfortunate is that for so long people were so obsessed with styles and they would talk about attachment style as if it were something like eye color or height. Once you've got this, you're stuck with it. And that's just not the case. And that's why I think it's great that we're
right.
taking style into account, but we're also branching out to
Yeah,
see how
the
style
brief
is one
ARE. It's
component
the
of something
BARE for brief
that's very
accessibility,
fluid and
responsiveness, and
interactive.
engagement skill.
So are
And
these
you can
bear
just click
questionnaires? Is that what you
highlight
were
it
mentioning
and
a
then
few minutes
download.
ago?
So there's three of them, the scoring, the items, and the article that I've just uploaded there. So it just came out, I think, last month in JMFT by our EFT supervisor, Jonathan Sandberg. So that's pretty fun. Well, Paul, we're coming to the end of our hour here, and I so appreciate what you're doing and just the confidence that
Wow.
it gives us to, go, hey, we have evidence,
Yeah.
and we're getting more evidence that EFT can help you, not only help your relationship, but help your health, right? And these are some pretty extreme populations with postpartum depression, diabetes, and heart disease. Those are some pretty heavy duty health issues, and chronic health issues. So it's fantastic that we can take a brief couple therapy and really help not only their satisfaction, but their physical health. And it makes all sorts of sense that that's happening. And so it's so exciting, your research.
It is, and as I said, we're just getting started. So there's a heck of a long way to go. But it's nice to see that structure there, to see EFT being more and more accepted into mainstream medical care, to get funding for it.
Okay, that would be great.
That's all very encouraging.
That'll be great.
Thank
And I'm
you
pulling
for
up a
having me,
web link
Becca.
here that people can
This
go
was
to.
a lot of fun
Just
for me.
letting you know about the
And
Creating Connection
I'll be
seminar
in
if you
touch. I'll
hadn't, that
send you
Sue's
those
coming
references
to.
that people were asking
Next
about.
year we'll all be there in Washington, D.C., so that should be really fun. So Paul, is there any help that you need from the community, from us? How can we support you and help you or contact you? Is there anything that you would like us to share with the community?
Well, just keep talking about this. Talk about EFT and health. We know about attachment in health. We know more and more about how important it is to be in a secure relationship, not just to have a secure style, but to be in a secure relationship in order to reap the benefits of good health. It's a matter of awareness. A lot of times people don't realize that dealing with their feelings about an illness is every bit as important to the future of that illness as taking their medicine. It's really a matter
So
of
that's
people
those are like
understanding
quotables,
just how
tweetables. You know,
important
I like to
relationships
be on social
are,
media.
not
That's a
just in
tweetable. It's just
managing
as
illness,
important
but
to
in
take care of
preventing
your
people from getting sick.
relationship for your health as it is to take your
So talk.
medicine. And it's true. Yeah. Right. Thank you, Paul, and thanks to everyone for joining us. Thank each of you
Absolutely,
for joining
absolutely.
in, and
And our
see you
grandmothers knew
on the
this, but
listserv
now
and
we
other
have proof
places
of it.
around our EFT world. Thank you. Bye. Bye.
All
Thank
right.